I'm ready,
B
man.
Mike, sidekick, you ready?
Your sidekick is ready, yeah.
Well, welcome back to Recommended Daily Dose. I am Dr. Clenton Coleman along with my colleague, Dr. Suraj Saggar. We have an amazing guest today, Dr. Sheneen Lalani. Now, she is literally on the front lines. Like, if there was a line, she'd be in front of it during this COVID pandemic. She is a hospice and palliative care physician in NYC. And you may have seen her on NBC News, Fox 5, ABC News, making Dr. Suraj look bad. You got to step your game up. No? She's
Yeah,
out
she gave
there.
me a run for my money, no
All
doubt
right.
about it.
So welcome, Dr. Lalani. How you doing?
Thank you. Thank you so much for having me. I absolutely love your podcast. And, I follow you on Instagram and I'm so excited to be here talking to you guys.
Awesome. So what are you up to now?
So I am currently at work. I am at my pop-up hospital in New York City. It's part of the HHC, New York City Health and Hospital Systems. And I am currently here as an internal medicine hospitalist and also as a palliative care doctor that they have hired. And I do locums full time. So they have hired me as the locum doctor here.
Right.
What made you go into hospice palliative care?
So I just want to talk about what palliative care and hospice
Sure.
first is. So palliative care is a field in medicine that deals with anyone that has a serious chronic illness. So that includes, cancer, end-stage heart disease, lung disease, dementia. So anyone with a chronic illness. And my job as a palliative care doctor is to provide relief of any symptoms like pain or difficulty breathing and suffering. And then my job is also to have goals of care conversations with patients and family. So, getting to know the patient at a deeper level and based on what their goals and wishes are, giving recommendations and helping them make medical decisions. And then mostly providing support to patients and family. And then the hospice side of it is hospice is for patients that have a life expectancy of 6 months or less. And with that, my job is also to, provide comfort, make sure they're comfortable, symptom management, and all of this works in a interdisciplinary setting where it's not just me, but it's the nurse, the social worker, the chaplain, and we all work together for these chronic illness and end of life patients.
So, there's no doubt that this is incredibly important, and we've actually had one or two hospice docs on before, but I find it so important to reiterate what it is and what services they provide, because I think you agree the general public still has some misconceptions about palliative care, hospice, and a lot of patients will sometimes think, oh, you mean you're giving up on me, right? That's something that Clinton and I deal with all the time. You're calling hospice, why? You don't care about me, you're giving up on me. And so what do we tell people, or what do we tell patients about that?
So I think every time a palliative care doctor is consulted, the first thing patients think of is hospice. And that's not true. Palliative care is not just hospice. It's for anyone that has a chronic illness. And our job is to help with any symptoms they might be having. And most importantly, start those goals of care conversations early. So start having open conversations about getting to know the patient about what is it that, life will really look like in the future, and kind of getting to know them at a deeper level. And that takes time. And that's why usually palliative care doctors are consulted early on in the disease progression. So we get to know them and help them make medical decisions based on what their goals and wishes are. So, it's not giving up. It's actually increasing the time you have and making sure that you're spending quality time with your family and spending quality time with yourself instead of, giving up, as people say.
Yeah, I think we do such a poor job overall as physicians, because I have patients who are in the emergency room and you're just asking what their advanced directives are, and they're like, why are you asking me that? Like, those conversations should be started in like the doctor's office as far as living will. It shouldn't be wait, to the last minute as far as decision making. Do you see some of those challenges? Like, what are the biggest challenges you see? I guess before this pandemic, which is a whole different animal, but as far as communicating end of life issues with family members.
So I think the biggest challenge is that we are involved too late on.
Right.
And that's hard, because then a lot of these conversations we're having is with family members when patients are unable to speak and be part of the conversation. So one thing I always suggest for physicians and even patients to do is just to even have a healthcare proxy form. Starting with something so basic is the most important part of initiating a conversation. So a healthcare proxy form is a form where you assign an agent, someone in your life, whether it is your spouse or your sibling or your children, one or two people, that in the event if you are no longer able to speak, who should we contact to make medical decisions for you? And it's medical decisions, not, financial decisions or anything like that, just medical decisions. And that is just a great way to start the conversation, because the rest of the conversation, whether it is regarding CPR or whether you want to go naturally or do you want to be intubated, those are difficult conversations, and we understand that. And it takes time to titrate up to that level sometimes. But just even starting with the healthcare proxy form that, hey, who should we contact if you are unable to speak, is a good gateway into other conversations.
That's excellent. I have a question. You're in New York, we're in Northern New Jersey, we're in the tri-state.
Mm-hmm.
We treat patients of a wide variety of backgrounds, caste, color, creed, etc. So, I run into difficulty. I mean, both Clinton and I deal with a lot of chronically ill patients, both as infectious disease and nephrology. You're taking care of a multitude of cultures and religions. So someone might say, oh, I'm Muslim, or I'm Jewish, I'm Christian, I'm Hindu. In our religions, we don't believe in giving up. We don't believe in this. So how do you reconcile people's cultural and religious beliefs in talking about end-of-life care? So I find this to be not only incredibly important, but it's also, I don't want to say difficult, but it does present itself often, and then we kind of, as physicians, are not always trained, okay, what are the intricacies of different religions and cultures even, and what they might have to say about end-of-life care, or what you can and can't do.
Yeah, so that is difficult, because especially in New York City, where we're, the hospitals in New York City are literally the melting pot, and we're seeing, different cultural backgrounds, like, for example, what we see with some Chinese cultures, where the patient relies heavily on the eldest in the family to make some medical decisions, or certain cultures, like whether it is the Jewish culture, where they don't believe in withdrawing care or anything like that. But a lot of it is just training yourself to change your language and have a more nuanced conversation. So for example, we never say things like we're withdrawing care, because that in some cultures is considered a negative thing, because we're not withdrawing care. We're still taking care of the patient, but it's in a different manner. We're taking care of the patient by focusing more on comfort and making sure they're comfortable. So a lot of, our training, especially being trained at NYU and getting my training at Bellevue for parts of my rotation, was learning how to use a different language when it comes to different cultures to kind of help them explain more of what is really going on with a patient. And this is when the interdisciplinary team comes in, so this is why it's not just me. We had a chaplain at Bellevue who was excellent, who was trained further in having these religious conversations with patients. And so if it's not just me and I'm coming in with someone that has, a very solid background in dealing with patients with different religious background, that also helps the conversation. And then we have social workers that are trained in having conversations with certain populations, whether it is the LGBTQ population or whether it is people from different socioeconomic backgrounds. So having that team approach is definitely beneficial. But you're right, it is very difficult.
But Clinton and I have talked about, in different minorities in medicine, underrepresented. Obviously, Asians are probably overrepresented. Do you find that having a background that you may have, and you can tell us about your background, that you're better able to relate to patients, or do you find that it helps you to relate to patients of a wide and varied background?
Yeah, so my background is I'm Indian. I was actually born in India, and I moved here when I was 10 years old.
That's right. Yeah.
Brown power.
And yeah, just having that background and knowing how family dynamics comes into play in our culture is just so important. And that's why, I always emphasize that a palliative care doctor is in conjunction with the primary team. We're never just alone. And so a lot of times we are enlisting help of physicians from different backgrounds, whether the physician is a Chinese background or a Korean background or a Japanese background, and just learning the nuances of where they come from and how patients' decisions are affected by where they come from. For example, I had a Buddhist patient and their end of life care is so different than, having, for example, a Native American patient. And when I've done locums all over the country and I've taken care of patients' end of life that are from Native American background, and having someone with me that understands the nuances of their culture is just so important, because there's no way I would know what to do.
You have a unique outlook during this COVID pandemic. We're seeing other places like Texas and Florida and California with spikes. Now, we all lived through this. How is your perspective as a palliative care physician dealing with, I guess, the volume of really sick people? We had whole committees in regards to end of life care and resources and things like that. So what was your experience like as a palliative care physician?
Yeah. So, what we went through here in our city and in where you guys are in Jersey, it was just nothing we could have ever imagined. Just the sheer volume of patients that were dying. As a hospitalist, I had so many patients die. And as a palliative care doctor, it was just so difficult. I would say the hardest part for me was to see that family members could not visit their dying loved ones. And a lot of what we did as the palliative care and hospice team is speak to family members about what was going on, explaining to them, where in the process the patient is. And the hardest part was, breaking bad news, telling these family members that the patient has passed away, and the family members couldn't visit their loved ones. And that, palliative care is a very touchy-feely field. We're all about, end-of-life care, being around your family, being around your loved ones, and to not be able to offer that for the patient and the family was definitely the most difficult part. What was your guys' experience
I agree
with that? Yeah.
No, I agree, because we kind of got, I was there trying to do clinical trials and make sure Clinton wasn't messing up, taking care of his kidney issues. But, we all had to pitch in and do family contacts and updates. And, there's plenty of times where I was there, just like I'm sure you were, FaceTiming with families, saying goodbye. Time with a patient right before he was intubated. Fully knowing at that point there was a good chance he would never come off, and he did succumb to his disease, or he said goodbye to his kids, or I'll be right back, Dad, I'll be right back. I FaceTimed with an Indian grandmother to their children, and in my mind they're saying goodbye, Dadima, which means grandmother, and I'm thinking to myself, that's what my kid would call my mom. So it really hit home. So, but you're right, that is a very unnatural way of having people saying goodbye and communicating, right? I mean, FaceTime or Skype, whatever it might be. I mean, how did you humanize that? Because I felt I thought that and it wasn't just me, it was obviously a lot of times the nurses, all doctors pitching in. But at the end of the day, we were trying to do our best, but it felt almost inhumane, or not inhumane, but it didn't feel natural.
It was callous.
Yeah, no, I think one of the most beautiful things I saw was that the nurses, the techs, the doctors and PCPAs, we all banded together during this time and provided palliative care to these patients, even if no one was a palliative care doctor. Everyone was assisting, like you said, with FaceTime, being next to the patient or being even next to the patient's room. The challenging part was this fear that this patient has COVID. And we had to, do our best to be next to the patient and, hold their hand, but at the same time also be aware that our safety is also important. And so dealing with that was also a difficult part for me, because there was this constant fear in the back of my head that I'm spending a lot of time in this patient's room, holding his hand and being there for him. But at the same time, back of my head, I was constantly thinking, okay, I need to be careful. I have to make sure there's no break in my skin. I have my full PPE on.
Yeah, of course.
And
yeah,
so,
you had those lines in your face, I'm sure, from the N95 mask. It was almost like a badge of honor, right?
Horrible. I had skin, hair breakdown because in the
Yeah.
beginning we were wearing them the entire day.
Yeah, and I feel like, I self-quarantine at home. I mean, Clinton did the same thing. You don't want to bring it home to your kids, to your wife.
Exactly.
I felt like as time went on, you kind of got used to it, and you get not more cavalier, but you weren't so fearful. But at the beginning, it was like, gee, I'm seeing 30, 40, 50 patients a day, and the anesthesiologists were intubating the patients. The critical care docs were putting in lines. We're there.
Yeah.
Histories, talking to patients. So you're right up in their face. But I did feel over time, you kind of got comfortable and realized that, hey, this is my job.
Definitely.
And once we didn't all, as healthcare workers, succumb, although we know that certain ones did. But in general, we knew that PPE works very well. I think we felt a little bit more comfortable. But it was still, like you said, a solidarity, not just all doctors, but doctors, nurses, techs, EMTs, ER docs, critical care docs, palliative care docs. It was really like you have a singular focus that you're just working on.
Exactly.
We all kind of dip our toes in the palliative care arena as well. Not that you can do, but we had to do it. But we were forced.
I know.
Yeah.
And it was just so beautiful to see.
Yeah, I think not only was it the volume that was hard to deal with, but it was the age difference, right? So we were initially we thought at 65 older and you had to be obese and diabetic and hypertensive, but you'd see 30-year-olds, 40-year-olds with no medical history, with kids, and it was. I think that was more depressing than anything else, and I'm sure you guys dealt with that too.
Those conversations were definitely the hardest ones to have with the family members, with the children. A lot of the conversations I had to have was with patients' family, like patient's wife or patient's husband and patient's children, and family constantly asking me, how do we talk to our children about this? How do we tell our family members about this? And children, sometimes I would have to talk to children on the phone just because it was just so much to handle for, their spouse. And children asking me, can I come see my dad? Can I come see my mom? And it was just so heartbreaking to say, no, I'm sorry for your protection. You can't come see your parent, So it was just, overall, it was just so emotionally challenging.
Yeah, because you're right. We're used to, and you don't want to sound cold, but we're used to having 85-year-old, 90-year-old patients pass away, et cetera. But it's just very unnatural to have a mid-40s with young children, 40s, had certain risk factors, obesity, diabetes, but nothing out of the ordinary that a lot of Americans experience. Because it happened so quickly and so fast, the acuity and the volume. It's almost like a tidal wave, that came in, and then all of a sudden it receded. Now we are, well, now I got a puppy, and that's why I was late, because I was playing with my puppy before I came today. So now things have calmed down, but we're waiting to see what happens in this, the rest of the summer and the fall.
Right.
I mean, I don't know. Any thoughts? Have you had any? As infectious disease, we have our own thoughts, but I mean, is there any insight you see? I mean, things are opening up in New York. I know you live in Williamsburg, but what do you see going on now? Are people kind of had it with quarantine? Do you think that people have quarantine fatigue and just are giving up on
I think definitely people have quarantine fatigue. I think people are starting to go out, but we are in phase 2, so people are allowed to be outside with proper, masks on and maintain proper distance. But one of the things we're actually seeing at my current pop-up hospital is the social fallout from all of this. A lot of patients at my current facility are ones that are now homeless, that were, very sick for a very long time and lost a spouse that was the breadwinner, and now they need placement. All these placement, like nursing homes, have backed up because of the amount of people that have gone into it, just because of a lot of, spouses being lost. A lot of elderly patients are starting to be more depressed because they've kind of lost their autonomy. And a lot of patients that we're seeing at our current hospital are homeless. And that is one of the social fallouts we are seeing from this disease. The financial hit some people have taken, also some, and just losing a family member that was a breadwinner. And that's happened a lot, especially with the elderly population. Are you guys seeing these fallouts at your
No, I think it's really
facility?
important that you mentioned it. I mean, we talk about deaths and morbidity and mortality, but you're right. The psychological, the psychosocial, the socioeconomic fallouts make the impact of COVID-19 even greater. Yeah, we're seeing it, or you're seeing it in people who are, refusing to come in for healthcare. So maybe their diabetes is out of control, or they're dying of heart attacks at home, or strokes, or But I think the psychological damage is certainly significant, not just in healthcare workers, but in people in general.
Yeah.
So I want to switch gears a little bit because not only are you on the front lines of COVID, you're on the front lines of socially active and responsible this wave. So you remember a wise woman once told LeBron James to shut up and dribble. Do you think physicians can still be
Should
activists?
stay in their lane.
Yeah, stay in your lane. Do you think physicians can be activists when it comes to social issues?
Yeah, I mean, I think as physicians, we are taught to, do no harm. And when we start seeing harm happening, I think it is our job to speak up and contribute to the movement. Yeah. And it can be in any way, just treating patients or having these conversations with patients. We already saw with COVID the health disparities. And that was a huge topic that everyone was discussing. So, I know people often say that, oh, you have to stay in your lane. But when people start dying, it is our lane, you know?
Or even beyond that, I think we're all minority physicians, and I'm sure we all experience racism, and I'm sure you experience sexism and ageism and all that things. That, it's different, I'm sure, in this metropolitan area, but are there some instances where you experience these things?
Yeah, I mean, I think being brown, and being a female, I think I experienced more microaggressions, especially when I travel to other cities outside of New York, in Middle America sometimes. But as a female, I experience sexism in medicine all the time. It's just being a female, younger physician, sometimes patients and people treat you differently. We already know of the income disparities. Women physicians tend to make less, and there's studies that show that. But not just that, just a lot of, micro-sexism, like patients being like, oh, hey, sweetie, or
when's the doctor coming in?
Yeah, when's the doctor coming in? Or where did you go to medical school?
Or they assume you're a nurse, right? Or something else, right? Yeah.
Right. And nothing wrong with,
of course not.
Assumed that
I'm
a nurse,
why
we love our nurses. Yeah. Right. But just, I don't think patients would be calling sweetie to a older male gentleman,
It depends.
You'd be surprised. A lot of patients call
you'd be surprised.
Sweetie.
I get the sweetie.
He looks so good. Yeah, he looks so
good. Oh, you get the sweetie?
They call me sir. I don't know. Maybe it's just the way my persona that I come across is very confident. But Coleman, he gets that sweetie.
But you're right. The microaggression, the casual racism, that. It's hard to explain that to people who don't appreciate it because it's not like overt racism, but it's still wrong, right? And I think we may be used to it. How many times someone's asked me to take away a tray or transport someone down the hall because they thought I was, someone else working in the hospital, not a physician. But I think that takes its toll. But, I guess outside of treating patients, equitably, are there anything that we can do as physicians, I guess outside of medicine, to make those experiences known?
I think just speaking up about them in non-medical settings, and just kind of lending our voice to everything that's been going on is just so important as a civilian and not just a physician. Just having open conversations with our own families and our own friends. And I always feel like these changes don't have to be huge. They can start off small in our own, friend and family settings.
Right, and it doesn't have to be Al Sharpton. It can be Dr. Suraj. It doesn't have to be.
Right, exactly.
It doesn't have to be Al Sharpton. Since we both have similar backgrounds, we know in India, for instance, you can't paint a picture of Indians in one paintbrush, right? There is racism within India of North. That's a whole show in of itself. So I think everyone has to kind of look inward, right? And kind of say, hey, there may be some racism in my own culture, even though I'm a minority. not all minorities love other minorities, right? I mean, or at least historically. So we know that there's a lot of work to do. It's not just a white and black issue, white, black, and brown issue. It's within each population. I think we have to kind of look inwards and say, you know what, there may have been some notions, preconceived notions, and things that have gone from generation to generation that need to stop. But Clint and I have talked about before that, we should not stay in our lane because racism is a public health issue, right? And so as infectious disease, I mean, that's what we do, public health. I mean, so I know a lot of doctors might say, like, we have enough on our plate, and now you're adding on that we have to discuss racial issues with patients. But I mean, I think it is, like you said, I mean, do no harm, but we have to not do no harm, we have to do good. And if we look at racism as a public health issue, just to look at gun violence and other issues, then we realize, hey, it's important to not just address it, but go out and be very vocal about it.
Definitely.
Social media or whatever in the news or whatever we can do to really bring light that, hey, we need to be agents of change. You like that, Clinton? Agents of change.
Agents of change. That sounds like the title.
Agents of change. I don't know. That sounds like a band. Maybe we'll keep that for something else. But
yeah, no, definitely. And I think now more than ever, social media has just become so common for physicians to use. I actually just started my doctor account about a month and a half ago because I was someone that, believe that too much of social media is not good for you.
Right.
There's studies that show that. And, but it has become a way we connect with people, especially during this pandemic where we can't go outside. And that was one of the big reasons. I mean, there's been such a bump in physician accounts, mine being one of them, and because I think a lot of physicians started feeling like, okay, this is our time to speak up, especially with the whole COVID situation that's happening, and lend our voice to whatever that is going on because it's important.
And I think it's really important. I admire you two both for what you do, is to lend our voices to the social issues that don't necessarily affect us directly, right? So, for example, Black Lives Matter is important to me. I'm sure it's important to you, but I think, we're obligated to speak out on all issues, whether they affect Black, brown, white, purple, gay, bisexual people, regardless of the case. So, anytime someone is suffering, I think it's all our responsibility to speak up for those people.
No, definitely.
Now, what's next for you besides pop-up hospitals and saving lives?
That's a busy plate. What else? I mean, I know you're doing a lot with media, so tell us a little bit about that, because we both do media as well. So it'll be very interesting to see what you're doing and what we could do better. How about that?
What you could do better. Yeah.
So I've been at this facility for a couple of months and depending on how long it's going to remain open, I've been working almost every day here. I've been having, I think I have about 5 or 6 days off a month. The majority of the time I am here just because of the sheer need that they have. And then after I'm done with this assignment, I feel like I need a little break and take some time off because I feel so exhausted.
Sure.
I don't know how you guys feel. I know we're not allowed to travel and I wish we could travel a little bit more. But I am just so tired. I feel like I've been going nonstop. When things were really bad, I was in the midst of it. And now I'm at this pop-up hospital and I feel like I've been going nonstop. And so it's just so important.
How does it work with these assignments though? With locum. Yeah. So you have, you're born in Texas, right? In Dallas?
Yeah.
You're not a 49ers fan. I'm sorry, a Dallas Cowboys fan, I hope.
Not really.
I'm from DC, so I'll leave it at that. I'm from Maryland, right after. So I support. So, but that aside, but you live in New York now? You live in Manhattan. You live in Williamsburg?
Yes, I moved to New York 10 years ago for medical school. I went to Toro.
Yeah.
And then I did my residency right after at New York City Health and Hospitals in Williamsburg area.
Right.
And then I went to NYU for palliative care fellowship. And then right after that, I started doing locums. I wanted to take some time to travel. I didn't really have a lot of money growing up. And so right after fellowship, I wanted to work a little bit and take some, whatever money I made, I wanted to go towards my loans and take some time to travel leisurely. And so locums was perfect because as a locum doctor, you have short contracts and you can make your schedule. And so I focused mostly on rural medicine, where I would go to rural areas like Missouri, or upstate like Corning, New York, where there's a sheer shortage of doctors. And so I could, practice hospitalist and palliative care, or sometimes even Indian reservations. So that was something I genuinely enjoyed, practicing in rural
That's interesting
areas.
because I found like most younger, because you're younger than us, physicians may say, I want to be in a city, I want to be more urban area or suburban area. But you were fine going to like very rural areas and practicing there?
Yeah.
You enjoyed
New York City, I enjoyed it because New York City was my base. So I would go for a week there, and then I would have a week off, and I would come back to New York City. So I felt like it let me enjoy New York City even more. And then also gave me kind of like an insight onto all these rural areas where there's a lot of shortage of doctors. I know a lot of doctors go internationally, but our country itself has a huge shortage in some areas. So
yeah, I've done some medical missions, and people like to say, I'm going here, I'm going to Africa, I'm going to some undeserved area in South America. But you're right. You look in our own backyard, right? And you just look.
Exactly.
And there's plenty of need here that still needs to be filled. But so are you planning to make a whole career? Because I know that we've talked to some physicians who, really their plan is not to do what Coleman and I do, which is private practice, and it has both benefits and, believe me, negatives.
Right.
But rather do locum so they can have that freedom and that flexibility in their schedule. Is that what you want? You do most locums do that long term, or it's unclear? I guess depends on how it
I think it's unclear. It depends. I don't have children right now, but I know once I have children, it will be hard for me to just go away for 2 weeks and then, But I know some locum doctors, like one of them that I'm working with right now, bring their children along with them. But I'm not exactly sure. But for right now, it does give me the opportunity to make my own schedule and get involved in other aspects of medicine, or, get involved in different hobbies, and not just make medicine all my life.
Now, Dr. Suraj, if you can't tell, is a little culturally impaired. So part of, I wanted to come up with a new segment where you make recommendations based on any music you're listening to or shows you're watching, just to make him, or books you're reading, just to make him a little more hip. You can tell by his shirt. Look, he has a collar out, taco meat showing.
First of all, it's a beautiful shirt. Yeah. You see all these books behind me. You see all these diplomas and books behind me. It's very varied. But we're not talking about me, so I digress. Right, tell us what's going on. Right. What are you reading this summer? Let's start with that.
Okay. So I would say one of the books I recently read not that long ago was a book called Sapiens. I don't know if you read that.
Oh, God.
I have read it. I have read it.
Coleman talks about this book like it's...
See?
No,
I have read it.
Bible, okay?
And Coleman doesn't even know what it means. It means, it's a fantastic book. But go ahead, give us a little review about that, because I love it. It's fantastic.
So basically, it's the history of human life. And I like books like that. And I think that's one of the biggest reasons I went into palliative care and hospice. It kind of just gives you a whole meaning of life, and it describes, how we started the civilization, why humans do what they do. And it's just so beautifully written. It's by Yuval Noah Harari. And it is my favorite book of all time. Anytime someone asks me for a book recommendation, I definitely say you have to read Sapiens.
He wrote another one, I think, too. He wrote a sequel to that, which I have not read.
Yeah, I think Homo Deus.
Yes, yeah.
Yeah. Yeah, so I think any book that kind of, changes the way you think about life and just humans in general is always interesting to me.
Any music?
What about, have you read any music?
Coleman doesn't read, unfortunately. He doesn't read much.
Audiobook.
He can't really offer us anything of any substance there.
Reading is the soul of the 1990s. Come on,
he does have a very good tennis shoe collection, though.
Tennis shoe.
Very good sneak collection.
Music. So I really like house music.
Basketball shoes, fine. Whatever, basketball shoes, tennis shoes.
I'm sorry, can you repeat that?
Sure. So I really like house and trance music. So that's kind of like the music genre. Recently, this band I've been listening to is called Rufus du Sol, and they have really good house music. I don't know if you're into house music.
Coleman's actually, I got Coleman into Bhangra, and he is just, yeah, he is like, this guy can Bhangra like no one knows. Even better than I'm a Punjabi, so even better than I can. So.
You rave from time to time, right?
I rave?
Yeah.
Yeah, I slowed down now that I'm a little older. I slowed down.
Great.
We just wanted to thank you. This has been very
Oh, thank
insightful. But before we
you.
go, where can people find you and follow you and all that stuff?
Sure. So you can follow me on my Instagram account. It's Dr.Lalani. So Dr.Lalani, Lalani. And then you can also add me on LinkedIn at Sheneen Lalani.
Awesome.
So those are the places. Thank you so much for having me. It was such a pleasure talking to both of you.
Complete pleasure. We really appreciate the insight you provided. We try to joke around and be light, but this is a difficult topic and a serious topic, a topic that needs to be discussed. And we really appreciate your expertise and enlightening all of us, but it's still in a very entertaining way. So we appreciate it very much. I'm still a little hurt you made fun of my music choices, but you know what? We always appreciate our listeners out there. Recommend Daily Dose. Find us on Apple Podcasts and Spotify. Until next time, I'm Dr. Suraj Saggar with my esteemed co-host Clenton Coleman. Be well.